Live and let die. Live and let die. Well, I'm not gone yet, and I can still play the guitar, still. But I've had some bad news, and it's to do with my neck. So let me explain. Excuse me. Yeah, basically, I'm getting great pains around this area of my neck, and I've had an MRI scan, and it's shown that some discs have been damaged, which are the pressure plates between the vertebrae at the top of the neck. Now the thing is, the neck contains all the nerves from the brain going down to your body, and the problem is, maybe it was early years when I was a paper boy, for 4 or 5 years, that heavy sack when you're still forming of papers. I used to remember getting a sore neck from that. And also, when I was singing in Paris, I didn't have a microphone stand, so I made one out of a couple of wire coat hangers. And, and then I began to experience also, and I went to see a doctor about this pain in the neck, and they said, neck brace, be careful what you put around your neck, there's loads of nerves there. But also playing the guitar strap that goes over your neck there, especially if it's a heavy electric guitar. Again, so when I've been busking recently, also my chronic fatigue, so I don't go out that often, I've come back with a very sore neck, and I had to plead with the doctor to get an MRI scan, and thank goodness I persevered, because I found out what the problem is. So I've done some research this afternoon, and I've put together this video about what the different vertebrae or discs between the vertebrae and the ligament that's been damaged, and why it's important I'm very, very careful with my neck from here on. Basically, the damage is done, it can only get worse, and playing the guitar will make it worse. So I've had to announce my retirement as a busker. Hopefully I can still play a few gigs, but I can't risk paralysis, So anyway, I've put together this video for my research this afternoon, so you'll know what's going on with me. And obviously I did this research, so I know more about what's actually going on inside and what the risks are. So hopefully this video will explain that.
The posterior longitudinal ligament functions along with the ligamentum flavum to prevent hyperflexion of the spine. It provides stability to the entire vertebral column along with the anterior longitudinal ligament and with the ligamentum flavum. The anterior longitudinal ligament prevents hyperextension, while the posterior longitudinal ligament and the ligamentum flavum prevent hyperflexion. The posterior longitudinal ligament is often abbreviated to the PLL. It runs along the posterior aspect of the vertebral body inside the vertebral column from the body of C2 to the sacrum. It is composed of longitudinal fibers that are denser than the fibers of the anterior longitudinal ligament. The denser fibers are deeper and span 1 vertebrae, while the superficial fibers span 3 to 4 vertebrae. The superficial layer is a continuation of the tectoral membrane at C2, and the deep layer is a continuation of the cruciform ligament at the atlas. Fibers are wider at the intervertebral spaces and are more adherent to the intervertebral disc than to the vertebral body, where they are thinner. This phenomenon is more visible in the posterior longitudinal ligament than in the anterior longitudinal ligament. The posterior longitudinal ligament is much thinner than the anterior longitudinal ligament, which is significant for the pathophysiology of disc herniations occurring posterior-lateral.
Osteophytes, also called bone spurs, are smooth outgrowths that appear around the edges of the vertebrae and on the facet joints. In order to understand why spinal osteophytes or bone spurs occur, it's helpful to know the basic anatomy of the spine. The spine is made up of 33 individual bones called vertebrae. The vertebrae are numbered and divided into 4 regions. A typical vertebra consists of a body and a vertebral arch, which has several processes for articular and muscular attachments. An intervertebral disc acts as a shock absorber between each of the vertebrae in the spinal column by keeping the vertebrae separated when there is an impact from activity. Facet joints are located between each pair of vertebrae. They guide and limit the movement of the spine, providing stability and bearing a share of the load on the spine. Osteophytes are commonly seen in the lower back, also called the lumbar spine, but they can occur anywhere in the spine. Sometimes osteophytes are found in places where they can put pressure on the spinal cord or nerve roots.
The C3, C4, and C5 vertebrae form the midsection of the cervical spine, near the base of the neck. Injuries to the nerves and tissues relating to the cervical region are the most severe of all spinal cord injuries, because the higher up in the spine an injury occurs, the more damage that is caused to the central nervous system. Depending on how severe the damage to the spinal cord is, the injury may be noted as complete or incomplete. C3 vertebrae. The C2 to C3 junction of the spinal column is important, as this is where flexion and extension occur. Flexion is the movement of the chin towards the chest, and extension is the backward movement of the head. Patients with spinal cord damage at the C3 level will have limited mobility in both their flexion and extension. Symptoms of a C3 level spinal cord injury. Symptoms of a spinal cord injury corresponding to C3 vertebrae include limited range of motion, loss of diaphragm function, requirement of a ventilator for breathing, paralysis in arms, hands, torso, and legs, trouble controlling bladder and bowel function. C4 vertebrae. The portion of the spinal cord which relates to the C4 vertebrae directly affects the diaphragm. Patients with C4 spinal cord injuries typically need 24-hour-a-day support to breathe and maintain oxygen levels. Symptoms of a C4 level spinal cord injury include loss of diaphragm function, potential requirement of a ventilator for breathing, limited range of motion, paralysis in arms, hands, torso, and legs, trouble controlling bladder and bowel function. C5 vertebrae. Damage to the spinal cord at the C5 vertebrae affects the vocal cords, biceps, and deltoid muscles in the upper arms. Unlike some of the higher cervical injuries, a patient with a C5 spinal cord injury will likely be able to breathe and speak on their own. Symptoms of a C5 level spinal cord injury include ability to speak and breathe in their own, but breathing will be weak. Paralysis in torso, legs, wrists, and hands. Paralysis may be experienced on one or both sides. Patients may be able to raise their arms and or bend their elbows. Patients will need assistance with daily living, but may have some independent function. C6, C7, and C8 spinal injuries. These vertebrae form the lowest levels of the cervical spine, near the base of the neck, and directly impact muscles in the arms and hands. The C6 and C7 vertebrae are the lowest levels of the cervical spine, near the base of the neck. Injuries to the spinal cord corresponding to these regions of the spine have the potential to impact everything below the top of the rib cage, resulting in quadriplegia. Though they often have better outcomes than higher cervical injuries, they are still considered incredibly severe because more damage is caused to the central nervous system the higher up in the spine the injury occurs. As is the case with any spinal cord injury, the damage is characterized as complete or incomplete depending on the severity. C6 vertebrae. Injury or pressure on the C6 nerve root that exits the spinal column between the C6 vertebrae and C7 vertebrae can directly affect the control of the muscles in the forearms and wrists. The symptoms of a C6 spinal cord injury may be experienced on one or both sides of the body, depending on the extent of the damage. Survivors of injuries at this level may be able to drive modified cars with hand controls. Symptoms of a C6 level spinal cord injury. Patients with spinal cord tissue or nerve damage near the C6 vertebrae often experience a false case of carpal tunnel syndrome. The patient will likely have numbness and/or tingling in the fingers, hands, and arms, paralysis in the legs, torso, and/or hands, inability to control the nerves that impact wrist extension, inability to control bladder and bowel function, ability to speak, but breathing may be taxed. C7 vertebrae. The portion of the spinal cord corresponding to the C7 vertebrae communicates with the tricep muscles. A survivor of a C7 spinal cord injury will likely have full neck movement, but may sense tingling and numbness in the hands and fingers, as well as referred pain in the shoulder blade. Symptoms of a C7 level spinal cord injury. Symptoms of a spinal cord injury corresponding to the C7 vertebrae include burning pain in the shoulder blade and/or back of the arms, known as the triceps, some ability to extend shoulders, arms, and fingers, but dexterity may be compromised in the hands and/or fingers, lack of control of the bowel and bladder, breathing again may be taxed, though the patient should not need ventilation. C8 spinal nerve. The C8 level corresponds to the region in which the nerve roots exit the spine between the cervical spine's C7 and the thoracic spine's T1. There is no corresponding vertebrae for C8. This nerve root is responsible for controlling muscles in the fingers and hands, and injuries to this area have similar symptoms to those at C6 and C7 levels. Depending on the completeness, a C8 injury will lead to paralysis of the legs, trunk, and hands, with patients maintaining shoulder and arm movement. Causes of cervical spinal cord injuries include motor vehicle accidents, falls, trauma, tumors, disease, and birth defects. Injury treatment. Treatment for spinal cord injuries is aimed at retaining as much function as possible while regaining lost function. Several therapy options may be tried to aid in spinal cord damage recovery. Physical therapy is an important part of the recovery. The patient will need to maintain any function not lost by the cord damage, as well as try to regain function. Surgery is done to stabilize the area around the spinal cord damage. The nerves around the damage are decompressed in hopes of relieving some of the symptoms. Fusion is then achieved by fixating the areas in and around the spinal cord damage. Medications, such as nonsteroidal anti-inflammatory drugs, are implemented to aid in recovering as much motor and/or sensory function as possible by reducing the inflammation in the area of the spinal cord damage. Mental therapy is also a very important part of treating spinal cord injury patients. The therapist can help the patient deal with the emotional side of recovery. Spinal cord injuries to the C6, C7, and C8 levels that are treated immediately have the best chance of recovery. Patients will typically know the extent of the long-term damage within 6 months of the injury. Learning to deal with the limitations of the injury is a very important part of the recovery phase. Keeping a positive attitude will aid the patient in pushing through surgeries and therapies. For additional information, please continue reading spinalcord.com.